We're going to talk about vitamin D and calcium, osteoporosis and beyond, new findings and recommendations. So we'll review the evidence of vitamin D and calcium in falls and fracture prevention, appreciate vitamin D's role in other tissues and on other systems, include the cardiovascular risk that was in the discussion a few years ago, and understand how to diagnose vitamin D deficiency and then how to treat vitamin D and calcium, and the Institute of Medicine recommendations. Vitamin D is both a hormone and a vitamin. So our body makes vitamin D, but oftentimes we don't make enough of it because we don't get enough sun exposure, and then we have to take it as a vitamin, as in our food or as a supplement. We make vitamin D in the skin in response to sun exposure. Cholesterol is turned into vitamin D3, and then in the liver it's turned into 25-hydroxyvitamin D, and then in the kidney it's turned into 1,25-hydroxyvitamin D, and then in the tissues it is used as calcitric acid. The sun makes vitamin D in our skin, and many practitioners will say, oh, you only need 5 or 15 minutes of sunshine a day to get enough vitamin D. I don't agree with that. Our vitamin D production depends on so many factors and the intensity of the sunshine, which is affected by if it's cloudy, if there's air pollution, if there's humidity in the air that blocks UV radiation, the time of day, the season, then latitude. North of the Atlanta latitude, people usually do not get enough sunshine to get vitamin D sufficiently. Then altitude, the higher the altitude, the more vitamin D production because there is less blocking of the UV radiation. And then skin tone. Someone as pigmentally challenged as I am will make 6 times as much vitamin D from the same sun exposure as somebody who's very dark-skinned. But there's definitely a seasonal variation with vitamin D, and with it comes an inverse relationship with parathyroid hormone, or PTH. So the more sunshine we have, the more vitamin D we make, and the lower the PTH level. This was a study that looked at 93 surfers. This study was done by a researcher here at University of Wisconsin-Madison. And yes, there are no surfers in the Midwest. He partnered with the University of Hawaii. And those surfers had, on average, a 29-hour sun exposure per week. But more than half of them had a vitamin D level of less than 30, which is considered by many as insufficient. The highest serum level was about 60 nanograms per milliliter. We don't really know why half of them did not have a sufficient amount of vitamin D in their serum. Maybe it's because they need less vitamin D and we should set the sufficiency range at a lower rate, or maybe we need more sun exposure than 29 hours per week. We don't really know. Either way, any excess vitamin D is turned by the sun into an inactive form and then is excreted by our kidneys, so we cannot get toxic by sun exposure. And that's why people who are living near the equator and walk around in shorts and a t-shirt don't get vitamin D toxic from sun exposure. So prevalence of deficiency, if measured at less than 20 nanograms per milliliter, in adults it's about 42%, in Hispanics it's about 70%, and in nursing home patients it's as high as 93%. This was a study out of Austria. In the US, our milk is supplied with vitamin D, so I suspect people who drink milk will have a slightly lower risk of vitamin D deficiency, but considering the high prevalence in nursing homes, it should cause us to pause and screen our nursing home or institutionalized patients. Blacks tend to have a higher prevalence of deficiency, likely due to genetically lower vitamin D binding protein in blacks, but the bioavailability of vitamin D seems to be the same. So maybe the cutoff for deficiency needs to be different for darker skinned people. and that might explain the higher prevalence in Hispanic patients. Production of vitamin D decreases in our skin as we age, so much so that we only make about 25% of the vitamin D at age 70 as we make at age 20 with the same sun exposure. Then we also don't convert as much of the vitamin D into the active form by our liver and our kidneys, and our gut receptors don't absorb as much vitamin D as we age, so we're at higher risk of deficiency, and that's why a senior multivitamin, for those over age 50, usually have higher levels of vitamin D, but also higher levels of vitamin B12, which is also less absorbed as we age. Obese adults have 50% lower vitamin D2 and D3 levels, and we don't know exactly why that is. We suspect maybe they're sequestering the vitamin D in the adipose tissue. We don't know for sure, because when patients lose weight, they don't seem to mobilize that and then raise their vitamin D level. There are actions of vitamin D throughout our body, and they can fall into two camps: an endocrine effect, which is mostly an effect on the kidney with calcium absorption, bone metabolism, blood pressure control, and insulin secretion. And then there are paracrine and autocrine effects on lots and lots of tissues, which include immune regulation, inhibition of cell proliferation, and promotion of cell differentiation. So we thought maybe it has an effect on cancer, so we'll talk more about that later. The vitamin D receptors are distributed widely throughout our body and can be found in most tissues. Inadequate vitamin D intake is very prevalent as we age, for the reasons that I've already explained with decreased absorption. And 90% of women over 70 do not get enough dietary vitamin D through a regular diet and need supplementation. Vitamin D deficiency, even in osteoporotic patients, so those patients who have osteoporosis, bone disease, and should be screened for vitamin D deficiency and should be replaced, about 50% of them have deficiency, depending on the level, on the cutoff that you use. So what can we do? We can use the parathyroid hormone as a marker of vitamin D deficiency, because when the vitamin D level goes down, parathyroid hormone goes up. So we have used the cutoff of 30, where the parathyroid hormone levels off, as the cutoff for deficiency. Some authorities say 20 should be the cutoff, because that's where the vitamin D levels, the parathyroid level tends to start plateauing. Laboratory evaluation sets the deficiency at less than 9 nanograms per milliliter, because lab values are established by taking the population mean and 2 standard deviations from that mean by the Gaussian curve. It has no clinical relevance at all, and that's why we use a different cutoff, usually 20 or higher as vitamin D sufficiency and 30 or higher for optimal bone health, rather than the 10 nanograms per milliliter. We usually measure 25 hydroxyvitamin D, although the 125 is the active vitamin D. That usually does not decrease unless a patient has kidney failure. And that's because as vitamin D deficiency occurs, the PTH increases, and the parathyroid hormone actually pushes the equation from the 25 hydroxyvitamin D to 125 hydroxyvitamin D. So even if a patient is vitamin D deficient, the 125 hydroxyvitamin D will always be normal in somebody with intact kidneys, but the 25 hydroxyvitamin D will be low. So that's the one to test. Before 2006, the assays were not reliable. They're much more reliable now and measure what they're supposed to measure. Cost is about $20 to $25, but check with your lab how much it costs. Medicare usually does not cover payment for vitamin D levels unless the patient has osteoporosis or some bone disease or some other cause of vitamin D deficiency, such as poor absorption from, let's say, celiac disease. Vitamin D has an effect on muscle and binds to the nuclear receptor in muscle, therefore increasing the de novo protein synthesis and increasing strength. And therefore it reduces the body sway and decreases the risk of falls. Vitamin D increases grip strength and decreases loss of appendicular skeletal muscle mass. 88% of women with muscle pain were found to be vitamin D deficient, and 93% with MS pain were vitamin D insufficient, and 28% vitamin D deficient. So have a high index of suspicion in your patients that have a history of MS or have a family history. Vitamin D helps with statin-associated myalgias, and many times when a patient comes to me saying that they don't tolerate statin but they need one for their cardiovascular protection, I will put them on vitamin D, and then on follow-up appointment 3 months later, I will restart their statin, and usually am successful to restarting it without the muscle aches anymore. Because of the effect on muscle, vitamin D has been shown to reduce falls. And the higher the pretest probability of falls, the higher the effect of vitamin D. So that in community dwelling, all comers, falls are reduced by 19%, but in those living in nursing homes where the prevalence of vitamin D deficiency is quite high, the falls have been reduced by 72% with an administration of 800 international units of vitamin D. So think of your patient's pre-test probability of having deficiency and then replace them. This is a study looking at the effect of vitamin D replacement, and low doses of less than 800 international units seem to be less effective than high doses of 800 or 700 or more. In community living elderly, it has also been shown to reduce falls. This study carried out for 2 years and showed falls reduction after a while, so we have to be patient about the effect. And this study was done to look at the cost effectiveness of treating patients with vitamin D supplementation for falls prevention. And when we consider a quality life year at $65,000, this is quite an effective and a nice deal at less than $700. Let's shift gears and talk about vitamin D's effect on bone. It transdifferentiates the bone marrow adipocytes into osteoblasts, which then will build bone, and it inhibits osteoblast apoptosis. Therefore, it can reduce fractures, and again, the higher the dose, the more effective, and the higher the pretest probability, the higher the effect on fracture reduction. And in this study with hip fracture reduction in patients with an average age of 83, there was a 43% reduction from vitamin D supplementation. There were some studies that came out saying vitamin D and calcium do not reduce fractures. Well, that when you read the detail of each study, it showed that the non-compliance rate and non-adherence was quite high, with over 50% of patients not taking the recommended doses 80% of the time. When they did a sub-analysis of these studies, they showed that patients who took 80% of their doses of vitamin D and calcium did have a reduction in fractures in all of these studies. So yes, intention to treat analysis showed no benefit, but if patients use vitamin D and calcium, it does reduce fractures. Calcium supplementation reduces fractures as well as vitamin D, and similar to bisphosphonates, which reduce fractures in the osteoporosis population, which has a very high risk of probability of having a fracture. Many of my patients will say, oh, I'm not supposed to take any calcium because of kidney stones. Yes, most kidney stones are calcium oxalate. However, it's not the calcium that causes the kidney stones. Part of it is insufficient fluid intake that does not wash out the calcium oxalate, but also insufficient calcium intake. Oxalate is included in lots of foods, including tea, spinach, and other green vegetables. And when we ingest it, it is absorbed and binds to the calcium in the blood. If we take sufficient calcium in our diet with the oxalate, it binds in the gut, and that large molecule then is not absorbed. And that's why many cultures, actually all cultures, combine spinach with some kind of dairy, such as yogurt or cheese, to block the absorption of oxalate. And these are two studies that actually showed reduced kidney stone formation in patients who were taking supplemental calcium. Vitamin D and calcium supplements, there are several different ones. Calcium carbonate has the highest amount of calcium per molecule. 40% of calcium carbonate is elemental calcium. Calcium citrate has only about half of the amount of calcium and therefore has to be formulated usually in 2 pills, otherwise it's such a huge horse pill that most people can't take it. So ask your patient which formulation they take to make sure that they're taking in adequate amounts, because if they only take 1 of the pills of calcium citrate, they may not be getting enough calcium in the day. Calcium citrate tends to be more expensive and not any better than calcium carbonate. There was some advertisement a few years ago that finally was pulled because it was false advertisement that stated that it is better absorbed when in reality it is not. Calcium carbonate is equally well absorbed as calcium citrate as long as it is taken in the vicinity of food or the patient has acid. The only time I would ever recommend calcium citrate is if the patient is on a proton pump inhibitor, so therefore has very aggressive acid suppression, and eats no food for the day during the days that the patient takes the calcium supplementation. Then I would use calcium citrate, but that is less than 5% of my patients. Calcium absorption is pretty low, and food definitely increases absorption. There is similar absorption of both formulations, whether if it's calcium citrate or calcium carbonate, as long as it is taken with food. But absorption really decreases after 500 milligrams of elemental calcium. So we really have to take calcium in divided doses, so 500 or 600 milligrams twice a day or even 3 times a day, depending on how much calcium there is in the water. And if any larger doses are taken, and some pharmacies still sell 1,000 or 1,200 milligrams of calcium pills, then patients should really break them in half, because any excess calcium over 500, 600 milligrams just sits in the gut and can contribute to constipation, because calcium is a muscle relaxant and it relaxes the smooth muscle, contributing to constipation if large amounts are taken. Usually the 500 or 600 milligrams do not cause constipation. Some patients read a study about increased cardiovascular risk and calcium a few years ago and stopped taking their calcium. This was a meta-analysis of 15 studies with 12,000 patients and looked at myocardial infarction, stroke, and death. There was a higher risk of the MI in the calcium group, but no statistically significant difference in the stroke, death, or combination of stroke, MI, and death. So in analysis, when I read this study, I found that these studies looked at calcium only administration, not in combination with vitamin D, and we usually don't administer calcium only anymore. We always also give vitamin D. There was no documentation on compliance, and as you saw, high non-compliance rate in those studies. And most of these studies did not look at high blood pressure, smoking, diabetes, coronary artery disease, or other risk factors for heart attack. Also, the endpoint was obtained due to patient report, death certificates, ICD-9 codes, and were not standardized and may not have been very accurate. Oftentimes we don't document very detailed when we write our notes, and more important and pressing issues are discussed at a visit. And many times our patients don't know. what has happened in the emergency room when they are asked. So one of the 15 authors of the meta-analysis was Richard Prince out of Australia, and he did a sub-analysis of his study looking at cardiovascular risk because he just couldn't believe the results of this study. So he looked at 1,400 women with an average age of 75. They were on 5 years of 1,200 milligrams of calcium or placebo and showed no increased risk of hospitalization or death. And in detailed analysis, the group with atherosclerotic vascular disease actually had a lower risk of events, heart attacks, or death with calcium than without calcium. So subsequently, a month or two later, the American Heart Association came out with a study looking at 3,200 articles and showed no difference in cardiovascular risk with calcium. There was also no difference with vitamin D or calcium and vitamin D. Possibly a slight benefit, but it did not reach statistical significance with vitamin D. So calcium and cardiovascular risk is mostly equivocal. One study showed a positive effect, that was this meta-analysis, and then a few studies showed negative effects, so protective effects actually. But I don't think that calcium has either a beneficial or a negative effect or bad effect on our heart. Now, vitamin D and cardiometabolic effect. Observational studies showed benefit, but a Women's Health Initiative large study showed no benefit in cardiovascular protection. However, again, only 60% achieved adherence, and the level was raised only to 21 nanograms per milliliter when the optimal level is considered greater than 30. So vitamin D and cardiovascular risk in most studies showed some protective effect and beneficial effect. But they're all observational studies, so stay tuned for randomized control trials. Let's talk about some other diseases and calcium and vitamin D. Depression seems to have improved with vitamin D of more than 800 international units in 15 randomized control trials. And then Cochrane also showed fewer occurrences of cancer, cardiovascular disease, and mortality with vitamin D administration. This was a study looking at walking speed, calcium administration, and colon cancer risk, and showed beneficial effects with higher levels of vitamin D and correction. Let me start with this slide over again. This slide looks at the risk of colon cancer associated with walking speed and vitamin D administration, and there was a direct relationship with higher vitamin D levels and lower colon cancer risk and improved walking time. This was a study looking at breast cancer in women in Nebraska and showed a reduction in cancers with vitamin D and calcium administration, no difference in the calcium-only group. And this author then also carried the study further, and after 10 years of follow-up, did another analysis of these women and showed no reduction of cancer in the long run. So I think that put the lid on that. Cochrane review says that vitamin D and calcium supplementation should be done in patients on corticosteroids because that leaches out the bone and causes osteoporosis. And then in elderly to prevent fractures. But during pregnancy, there is not enough data to show any benefit of vitamin D and calcium during pregnancy. And one study actually even looked at bone mineral density in children at age 6 years for women who had been supplemented with vitamin D during pregnancy and showed no difference. Vitamin D and atherosclerosis. There is upregulation of the renin-angiotensin system with vitamin D deficiency that can lead to hypertrophy of the left ventricle and the vascular smooth muscle, and therefore may be contributing to hypertension and atherosclerosis. And low and high levels of vitamin D have been shown to increase the risk of atherosclerosis. So it's kind of like Goldilocks, not too low, not too high, you want it just right. The immune system, vitamin D has lots of effects on various portions of the immune system, so we were thinking that maybe it has an effect on cancer and other diseases that are affected by the immune system, and has been shown to cause bacterial killing, superoxide synthesis, and macrophage activating, making the macrophage more aggressive, especially in tuberculosis. And there's been a variant in the vitamin D receptor that has been shown to protect patients from TB, but it also increases patients for osteoporosis risk. So vitamin D induces antimicrobial peptide in monocytes and therefore makes those immune cells more aggressive towards various bacteria. And in this study, addition of vitamin D to TB treatment improved clinical outcomes and X-ray findings and lab results in the treatment of TB. There is a subgroup of patients with the TT phenotype of the vitamin D receptor that speeded the sputum culture conversion to negative compared to controls. So certain cultures are more susceptible to vitamin D augmentation in their TB treatment. In the adaptive immune system, the vitamin D has an effect on the T cell differentiation and proliferation, and the helper T cell activity, and IL-2 B cell production. So that might have implications on autoimmune diseases such as psoriasis or multiple sclerosis. And topical vitamin D, such as calcipotriene, decreases skin proliferation and is indicated in the treatment of psoriasis. And in multiple sclerosis, supplemental vitamin D has been shown to have lower incidence of MS in the Nurses' Health Study. So the IOM report concluded that there's no solid evidence supporting other diseases other than bone health, and even though muscle has a strong support for vitamin D reducing falls, the Institute of Medicine report does not feel that the evidence is strong enough and therefore only endorses vitamin D supplementation for bone health. So most vitamin D and osteoporosis researchers recommend 1,000 international units of vitamin D a day, but the National Osteoporosis Foundation recommends that as well. However, the Institute of Medicine report came out in 2010 with a recommendation of 600 international units for most adults and children, and 800 international units for those over 70, our older adults. These are the more detailed recommendation for calcium and vitamin D from the Institute of Medicine report from 2010. Toxicity is considered at a level of 4,000 international units daily. So a strong body of evidence supported vitamin D and calcium for bone health, but usually not any other tissues. So what amount of vitamin D is required to keep the level in the therapeutic range, so above 20 or optimally 30 nanograms per milliliter? This study looked at, was a European study, so they're measuring nanomoles per liter, and there are it has to be divided by 2.5 to get our nanograms per milliliter. So most patients were sufficiently supplemented with 800 international units to get their level above the therapeutic, into the therapeutic range. So 800 international units increased the serum level to 20 nanograms in 97% of deficient women. And those were average age of 67. There are several medications that can accelerate the vitamin D metabolism in the liver, primarily seizure medications such as phenytoin and phenobarbital. And glucocorticoids inhibit the vitamin D-mediated calcium absorption in the gut and deposition in bone, and therefore the recommendation of the USPSTF to replace patients with vitamin D and calcium who are on corticosteroids. So which vitamin D should we recommend? Vitamin D2 or vitamin D3? Vitamin D2 is made by fungi, including the fungi that live on fruits and vegetables, but that we nowadays wash off because of pesticide use. Vitamin D3 is made in our skin. So think vitamin D3, cholecalciferol, the third letter in the alphabet, and is made by the sun, which also has 3 letters in it. So cholecalciferol, vitamin D3, is produced by sunlight. Both undergo the same conversion in the kidney and have the same tissue effects in the body. A couple of studies showed equal potency, and a couple of studies showed that vitamin D3 is a little bit more effective, and vitamin D2 only about 70% as effective as D3, and that is probably because of intermittent dosing. Vitamin D2 seems to be metabolized more rapidly than D3, so that after 2 weeks, the vitamin D2 level after a supplemental dose is below the pre-treatment dose, whereas the D3 continues to stay above pre-treatment dose after a month even. So as long as patients take it every day, I tell them to just buy whichever is cheaper, D2 or D3. But if they were to take it intermittently, then the D3 would be better. We have really moved away from intermittent treatment. Use in kidney failure, because the kidney cannot convert the 25-hydroxyvitamin D to the 125-hydroxyvitamin D, we really need to use the calcitriol, the end product of vitamin D, but that can lead to hypercalcemia and then calciphylaxis. So we're trying to come up with newer formulations of vitamin D that still have effects on our tissues without causing the hypercalcemia that could contribute to the calciphylaxis. So calcitroic acid is the most potent of them, which is more potent than the 125-hydroxyvitamin D and more potent than the 25-hydroxyvitamin D. So these are various foods containing vitamin D naturally, and we should eat more fish. So particularly the lower fish such as salmon, mackerel, or herring have good amounts of vitamin D without containing the high levels of mercury that the higher level fish can contain. These were 2 studies that examined high-dose vitamin D administration that has changed my management practice. We used to would replace vitamin D deficiency with weekly administration of vitamin D, but this first study showed increased risk of falls and increased fractures with a once-yearly dose of 500,000 international units of vitamin D, which is equivalent to about 800 international units daily. And we didn't know why that happened. We thought maybe there's an antibody production against vitamin D that happens, but the falls and fractures occurred within the first month, not enough time to develop antibodies. And then a more recent study showed that 60,000 international units monthly increased the risk of falls in community living older adults over 70. So we're really moving away from high doses intermittent formulations and giving lower doses on a daily basis. The Institute of Medicine report thinks that toxicity will occur at levels over 4,000 international units in adults and 3,000 in children and 2,500 in 1 to 3-year-old toddlers. Several studies have shown no toxicity from even high doses as much as 10,000 international units daily, and that is probably because these patients got some sun exposure, which then inactivated any excess vitamin D. However, in institutionalized patients who do not go out into the sunshine, we have to be careful and not use very high doses or monitor their vitamin D level periodically, because very high levels of vitamin D can cause atherosclerosis in levels of greater than 89 nanograms per milliliter, just like low levels of vitamin D can cause atherosclerosis too. Also, you can get hypercalcemia from very high levels of vitamin D, but like I said, most excess vitamin D is degraded by the sun as long as we get some exposure to the sun. Several associations and societies have recommendations for vitamin D. So the American Geriatric Society recommends 4,000 international units daily along with calcium for older adults, and that's because absorption really decreases in older adults. AMDA recommends 1,000 international units daily to prevent falls. And the Osteoporosis Foundation in Canada recommends 800 to 2,000 international units with optimal treatment of more than 1,000 international units. The USPSTF recommends in high-risk elderly populations to supplement with 800 to 1,000 international units daily, and the Endocrine Society recommends to raise the vitamin D level above 30 nanograms per deciliter per milliliter, and recommends at least 800 international units, but usually 1,500 to 2,000 international units to accomplish that. We already talked about the Institute of Medicine report, so 800 international units a day for older adults. So in conclusion, there is a high rate of vitamin D deficiency in older adults. Supplement with vitamin D and calcium in older adults, which can reduce fractures and falls, with 800 to 1,000 international units daily, and calcium 500 to 600 milligrams twice daily. The evidence is insufficient if vitamin D or calcium increases or reduces cardiovascular risk, and we need more data on other health benefits of vitamin D. Thank you.